Ladies and gentlemen, esteemed doctors, a very good evening and warm welcome to all. I trust that you are doing great and in the pink of health. Thank you for making time, and it's certainly our pleasure to host this evening's Subregional Medical Symposium webinar entitled Advances in Management of Urothelial Carcinoma. For your information, this session is being recorded. Please provide your consent by clicking continue. Although all attendees are muted throughout the webinar, we encourage your participation by submitting your questions, if any. We will compile these questions for discussion during our Q&A session later, and I'm sure our panel of experts are more than glad to address them as time permits. If I may have your attention to the presentation slide now, please allow me to quickly guide you on how to raise questions. For those of you who are joining this webinar via personal computers, you will see a similar screen as shown. The first button, which resembles a microphone, will stay muted throughout the webinar, whereas the next button is the virtual raise hand function, which you may use if you have difficulty in participating in this webinar. Next, you may use the questions and answers button to send in your questions. For those of you who are joining this webinar via mobile devices, be it mobile phones or tablets, you will see a similar screen as shown. The button which resembles a hand is the virtual raise hand function, which you may use if you have difficulty in participating in this webinar. We also have the questions button, which you may use to send in your questions. Lastly, we will be conducting polls in this webinar. Your opinions and participation are highly valued. Please do click to select your choice of answer when you see the poll question displayed. And without further ado, let's warmly welcome our chairperson, Dr. Robert John Walsh, Associate Consultant, Medical Oncologist at the National Cancer Institute of Singapore. The stage is yours, Dr. Robert.
Thank you for the introduction, and good evening to everyone who has joined the webinar, and thanks for joining. So just a quick disclaimer before we sort of get going. You can read that. Essentially, the following presentation is for healthcare professionals only, and the opinions reflect those of the presenters and not that of Merck. Okay, so we can just have a quick run through of the agenda today. So we've got a great panel for discussion and excellent speaker. So first we'll be joined by Dr. Tanuja Rajasekaran, who is going to take us through the recent advances in the management of urothelial carcinoma. We'll have a short period for question and answer, so please do pop your questions in the Q&A box if you have any that come to mind. We'll be happy to go through those. Following that, we'll go on to a panel discussion where we'll be joined by Dr. Daniel Wong from Malaysia, Dr. Wulio Rajapto from Indonesia, and Dr. Gerardo Cornelio from the Philippines. So we'll be hearing, getting some local cases from our panel, and then we'll be having some time for discussion. And again, I'm happy to answer any questions that come up along the way. So I'd now just like to introduce our speaker, Dr. Tanuja Rajasekaran. So Dr. Tanuja is a senior consultant currently practicing at the Parkway Cancer Center in Singapore. So Dr. Tanuja has special interest in management of lung, GU, head and neck cancers, as well as geriatric oncology. Previously, Dr. Tanuja served as a consultant at the National Cancer Center of Singapore. And her undergraduate training was undertaken at the National University of Singapore, where she was awarded the Dean's List for Undergraduate Studies in 2006. Her postgraduate qualifications, both Masters of Medicine, also MRCP, and subsequently completed training in medical oncology at the National Cancer Center of Singapore. She's actively involved in medical education, core faculty, the Medical Oncology Senior Residency Program, as well as a clinical lecturer at the Yong-Loo Lin School of Medicine, NUS, and an assistant professor at the Duke NUS Medical School. She's widely published in internationally renowned journals and members of several professional bodies. See here. She has received numerous awards, most recently the ESMO Fellowship Grant for her research in geriatric oncology in 2022. So without further ado, I'd like to let Dr. Tanuja take away with her talk on the advances in management of urothelial cancer. Dr. Tanuja.
Thanks very much, Robert, for the very kind introduction. Good evening, everyone. It's good to see everyone virtually here, and thanks to Merck for this invitation. Let me just try to share my slides and then we can begin. Just give me a minute. Let me bring up my slides. Can you see my slides?
Yes, we can.
Okay, and in the slideshow mode?
Yes, it is.
Okay, fantastic. So thanks again, everyone, for joining us. Today, my talk is titled Advances in Management of Urothelial Cancer, and these are my disclosures. This will be the outline of my talk. I'll be first covering the frontline management of advanced urothelial cancer, and then we'll talk about what happens in second line treatment and beyond, and how do we sequence our treatment. And we also, at the end, we'll also cover a little bit about what do we think advanced urothelial cancer is going to look like in the future. And thereafter, I'll be happy to take any questions that you have. So I'll start off by saying, I think for most of us oncologists who treat urothelial cancers, bladder cancer, we know that unfortunately, bladder cancers have a very poor outcome. The 5-year survival rate for patients with stage 4 bladder cancer is very dismal. It's less than 10%. And even for patients with muscle invasive bladder cancer, after going through neoadjuvant chemotherapy, cystectomy, their chances of relapse to metastatic disease is very, very high. So let's say currently, what is our frontline management of advanced urothelial cancer? Essentially, for standard of care for a long time has been a platinum doublet treatment, usually with either cisplatin or carboplatin together with gemcitabine. That has been standard of care. There's been a lot of debate whether should you use cisplatin, should you use carboplatin, which is better. And this debate, people have been debating this question for the longest time, and I think there's really no one good answer to this. But my take on this, based on all the first line IO plus chemotherapy trials that have been published, is generally they are fairly equivalent. If you look at the graphs, here, essentially in terms of median progression-free survival, whether you use carboplatin or cisplatin, generally very similar progression-free survival rates. In terms of responses, whether you use carboplatin or cisplatin, again, very similar response rates. When it comes to median overall survival, there seems to be a little bit of benefit with cisplatin. And but if you look at the curves, they cross as well. So essentially, for my patients, if they have a creatinine clearance that is more than 60 mils per minute and they are fit for cisplatin, I will go ahead with cisplatin. If your creatinine clearance is not good enough for cisplatin, then I won't think too much about it. I'll just go ahead with carboplatin. If you have a creatinine clearance of 50 to 60 mils, I know people always debate whether should you do a split dose of cisplatin day 1, day 8. My take on this is don't be too fussed about it. Just give your patient carboplatin. They will do just as well. More importantly, it's important for your patient to get the chemotherapy. Okay, so this has been the treatment algorithm for frontline metastatic urothelial cancer cisplatin eligible patients. They would get cisplatin plus gemcitabine for 4 to 6 cycles, and then they will have a wait and watch approach until they progress, and then we start second line treatment. For patients who are cisplatin ineligible and they're still able to go for chemotherapy, they'll get carboplatin plus gemcitabine. And previously, there was this label by FDA: if patients were cisplatin ineligible and PD-L1 positive, there was a role for atezolizumab and pembrolizumab. Again, this label has changed. We'll talk about that in the later slides. But based on this treatment, you realize that patients who have had frontline treatment, only about 25 to 55% of patients actually move on to second line treatment. And if you look at the responses, whichever chemotherapy regimen you use, generally patients get a fairly good response with first-line platinum doublet treatment. Response rates are in the range of 65 to 75%. Most of the patients, again, as mentioned, get 4 to 6 cycles of chemotherapy. Most people don't get anything more than 6 cycles because of the toxicities. But you can see with first-line chemotherapy options, median PFS generally is 6 to 8 months, and overall survival is 9 to 14 months, which is really fairly dismal. And of course, for patients who have risk factors such as visceral mets, poor performance status, their overall survival is even less than the 9 to 14 months that is stated here. And so what we have tried to do is see how we can move things forward for our patients with metastatic urothelial cancer. Just like in many other cancers, we tried to see whether the addition of immune checkpoint inhibitors in the frontline setting together with chemotherapy would make a difference. And there are many trials that have looked at this, as you can see on my slide here. Unfortunately, all the frontline trials that have used immune checkpoint inhibitors together with platinum doublet chemotherapy has been negative thus far. And so far, the only trial that has been positive is the Javelin 100, which has used avelumab maintenance, which we will talk about in a bit. And based on all this data that has come out from the frontline immunotherapy trials in combination with chemotherapy, we've realized that immune checkpoint inhibitors may not be as good in the frontline setting as it was initially thought to be. And so in 2021, FDA removed pembrolizumab's approval for PD-L1 positive tumors in patients who are cisplatin ineligible. And this label was converted to this label was converted for approval in platinum ineligible patients. So for cisplatin ineligible patients with PD-L1 positive tumors, there is no FDA approval for first-line pembrolizumab anymore. It has now been converted to platinum ineligible patients. How do we decide whether a patient is platinum ineligible? You look at the blue box at the bottom. This is the Gupta criteria. This has been defined. Platinum ineligible has been defined as patients with an ECOG performance status of more than 3, creatinine clearance of less than 30 mL per minute, peripheral neuropathy that is grade 2 or more, NYHA class 3 heart failure, poor performance status, and poor performance status and poor creatinine clearance. Essentially, when I look at this criteria, this to me looks the same as chemotherapy ineligible, looks like chemotherapy ineligible patients as well. Whether pembrolizumab would work in this indication is a little bit of a question mark. And similarly, atezolizumab has also withdrawn its indication for use in urothelial carcinoma. This is something to note. And so we move on to talk about the Javelin Bladder 100. This is essentially the only frontline immunotherapy trial that has been positive. So the key eligibility criteria for this trial, they recruited patients with unresectable, locally advanced or metastatic urothelial cancer. Patients must have received 4 to 6 cycles of platinum-containing chemotherapy. It was either gemcitabine plus cisplatin or gemcitabine plus carboplatin. Patients required to have a good performance status, ECOG 0 or 1, and patients who had achieved either a complete response, partial response, or stable disease to their frontline chemotherapy were then randomized to either avelumab or just best supportive care alone. Avelumab was given at 10 milligrams per kg every 2 weeks. And this is until disease progression. The primary outcome was overall survival. Secondary outcomes was, as stated there, progression-free survival, response rates, etc. So this is the baseline characteristics of the patients that were included in the Javelin 100 trial. Most, you can see the baseline characteristics are balanced between both arms. Most patients are in their late 60s, mostly males, and about half of the patients had gemcitabine cisplatin, and another half had gemcitabine carboplatin. And a good proportion of patients, about 54% of patients in both arms, had visceral metastatic disease. And if you look at the bottom here, you can see most of the patients had either a complete response or a partial response to first-line chemotherapy. The rate of this was about 72%, and about 27% of patients had stable disease. And if you look at the primary endpoint of this study, which is the overall survival, this is definitely a positive study. Median overall survival is 23.8 months in the avelumab arm versus 15 months in the best supportive care arm. Hazard ratio is 0.76, and p-value was statistically significant. So essentially, patients receiving avelumab had a 31% decrease in the risk of death compared to the best supportive care arm. And you can see that this is the forest plot looking at the subgroup analysis to see which are the patients that benefited. And you can see essentially all the subgroup tested, whether patients irregardless of their PD-L1 status, their race, their age, patients benefited from avelumab maintenance after chemotherapy. And again, you look at this chart, you can see patients, regardless of their initial response to chemotherapy, whether it was a CR, PR, or stable disease, patients benefited from the addition of avelumab. And again, whichever chemotherapy regimen that they have, be it gemcitabine, cisplatin, or whether gemcitabine, carboplatin, you can see both, whichever regimen they had, the patients benefited from getting avelumab maintenance. And similarly, regardless of the number of cycles of chemotherapy they got, whether it was 4 or 6 cycles, overall survival was prolonged in these patients who got avelumab. So this is the secondary endpoint looking at progression-free survival. Median progression-free survival was 5.5 months in the avelumab arm versus 2.1 months in the best supportive care arm. Hazard ratio was 0.54 with a significant p-value as well. And then we look at overall response. Remember, we mentioned most of this, 70% of the patients who were enrolled in this trial already had either a complete response or a partial response. And with the addition of avelumab, patients in the avelumab, the response rates of the patients in the avelumab group was about 10%. Again, this probably added to the positive overall survival in the patients as well. So you can see this, this is the patient-reported outcomes, where basically there's really no difference between the patients who had avelumab and best supportive care. They had very similar quality of life based on the graphs that we can see here. And this chart looks at the subsequent therapy that patients had, and if you look at the patients on the best supportive care arm, close to 72% of patients went on to get subsequent therapy, and of these subsequent therapies, about 53% of patients had immune checkpoint inhibitor. So again, in terms of safety profile, no new safety signals were analyzed. Safety profile was very in keeping with the immune checkpoint inhibitor. And you can see the most common treatment-related adverse events were urinary tract infections and diarrhea. And they had one patient had an immune-related death, which was secondary to immune-mediated nephritis. Otherwise, no new safety signals were detected. So just a quick summary of the Javelin Bladder 100 study. So essentially, this is the only positive immune checkpoint inhibitor trial in the frontline setting. There's an improvement in overall survival and progression-free survival. And generally, the treatment is safe as well. So these are some other key chemotherapy maintenance trials that are being conducted, and we await the results. So there's the DISCUS trial, which again which looks at patients with first-line metastatic urothelial cancer, and patients are randomized to either 3 or 6 cycles of platinum chemotherapy followed by avelumab maintenance. And this is an important trial because we are trying to see whether we can de-escalate treatment for our patients. The other trial that is ongoing now in the upfront setting is the MAINCARE trial. This is for patients with metastatic urothelial cancer and those who have had benefit from first-line platinum-based chemotherapy. Patients are then randomized to either avelumab maintenance or a combination of cabozantinib and avelumab, and we await the data for these studies. So for frontline setting now, standard of care for patients with advanced or metastatic urothelial cancer essentially is chemotherapy with a platinum doublet. It doesn't matter whether you get cisplatin or carboplatin, it's just a platinum doublet, and patients who respond go on to get avelumab maintenance. So should patients progress, what should be the next line of therapy? Before we had avelumab maintenance, most patients just had chemotherapy, and second line, based on the KEYNOTE-045 study, patients would go on to have pembrolizumab. But now that patients have had seen immune checkpoint inhibitors with avelumab in the first line setting, what do we use in our second line treatment? So we'll talk about that in the next few slides. So basically, the new kid on the block for urothelial cancers now is antibody drug conjugates, and there are basically 2 antibody drug conjugates that have been approved by FDA, which is for use in urothelial cancer, and enfortumab vedotin and sacituzumab govitecan. Both these antibody drug conjugates have different targets as well as different chemotherapy payloads. And enfortumab vedotin targets Nectin-4, and the chemotherapy payload is MMAE, which is monomethyl auristatin E. And sacituzumab govitecan targets TROP2, and its chemotherapy payload is SN38, which is an active metabolite of irinotecan. And so what exactly is an antibody drug conjugate? Essentially, what happens is that there's an antibody that is created to target antigens that are expressed specifically by the cancer cell. This antibody is via a linker is attached to the cytotoxic drug, whichever it may be. So this is how an antibody drug conjugate looks like, and this is how essentially it works. So you've got an antibody drug conjugate. It recognizes the antigen that is expressed on the cancer cell. This binding of the ADC to the antigen receptor results in the ADC receptor complex being internalized. And once this ADC receptor complex is degraded, the chemotherapy payload is released, and this results in cell death and the death of the cancer cells. Why is this better than just chemotherapy alone? Because this is particularly targeted to the cancer cells that express the antigen, number one. Number two, because this the chemotherapy toxicities are localized to the cancer cell, higher doses can be given with antibody drug conjugates. So the enfortumab vedotin was studied in the phase 3 EV01 study, and so this trial looked at patients who had received prior treatment with PD-1 immune checkpoint inhibitors as well as platinum-based chemotherapy, and they were then randomized to either enfortumab vedotin or standard chemotherapy, which was based on investigator's choice. It could either be docetaxel, paclitaxel, or vinflunin, and enfortumab vedotin was given at a dose of 1.25 mg per kg on day 1, day 8, day 15 in a 28-day cycle, and patients were allowed to continue on treatment. until disease progression, and the primary endpoint was overall survival. And if you look at this, and if you look at the treatment characteristics of the patient in this trial, these were patients who were heavily pre-treated. 13% of patients had more than 3 lines of prior systemic therapy. 69% of patients had not responded to immune checkpoint inhibitors, and 80% of patients had visceral metastatic disease. So essentially, a patient cohort that doesn't have very favorable risk factors. But despite that, this is a positive trial. There's a median overall survival of 12.9 months in the enfortumab vedotin arm versus 9 months in the chemotherapy arm. This hazard ratio was 0.7, and p-value was statistically significant. And there was also an improvement in progression-free survival. Median progression-free survival was 5.5 months in the EV arm versus 3.7 months in the chemotherapy arm. And in terms of response rates, the response rates for EV in this heavily pre-treated population was about 40% compared to about 17% in the chemotherapy population. So the other immune antibody drug conjugate that I spoke about is sacituzumab govitecan. It's directed against TROP2, and TROP2 is epithelial surface antigen that is highly expressed on urothelial cancer cells, and sacituzumab govitecan has been used in patients with metastatic triple-negative breast cancer, and there is phase 3 trials for its use in urothelial cancer is ongoing. But there was a Trophy 01 study for the cohort. There was a cohort 1 of patients, essentially 100 patients who had patients who essentially progressed on chemotherapy as well as immune checkpoint inhibitors, and they were given sacituzumab govitecan, and you can see here that the response rate was about 30%. And these are again a very heavily pre-treated patient population. About some of these patients in this cohort had also received enfortumab vedotin, which was the antibody drug conjugate that we spoke about early on. So the median PFS is 5.4 months based on this phase 2 cohort, as well as median overall survival of 10.9 months. So again, very promising results, but we await the phase 3 study, which is the TROPiCS-04 study, looking at a very similar population to the EV301 study. We await this study, will probably read out fairly soon. So how about targeted therapy? So for patients, we know that in about 20% of patients with metastatic urothelial cancer, patients have FGFR alterations, and this erdafitinib is a pan-FGFR inhibitor, which has shown activity in the single-arm phase 2 trial, which is the BLC 2001 trial. This trial, erdafitinib, was used in patients with FGFR-altered urothelial cancer, and response rates were 40%. Median PFS was 5.5 months, and overall survival 11.3 months. So again, very promising results. And this was further studied. Sorry. This erdafitinib was further studied in the TOR design. So for patients who have advanced urothelial cancer with FGFR alteration, they were divided into 2 cohorts. The first cohort was patients who had prior treatment with PD-L1 inhibitor. For those patients who had prior treatment with PD-L1 inhibitors, they were randomized to either erdafitinib or chemotherapy. For patients who have not seen immune checkpoint inhibitors, they were randomized to erdafitinib versus pembrolizumab. So far, only cohort 1 has been read out, and this study was presented. In ESCO just in June recently. So patients who had prior systemic treatment, chemotherapy, immune checkpoint inhibitors, they were randomized to erdafitinib at a dose of 8 milligrams with a possibility for up titration or chemotherapy, which was either docetaxel or vinflunin, and primary endpoint was overall survival. And this was the patient characteristics, and you can see most of the patients had at least quite a number of patients had at least 2 prior lines of systemic therapy, and this patient population seemed to have a very low PDL1 score. This is not unexpected, especially in a patient population that is driven by FGFR alterations. So okay, so this is the primary endpoint of overall survival. This was a positive study. Median overall survival compared to chemotherapy using erdafitinib was improved compared to chemotherapy. Median overall survival was 12 months versus 7.8 months in the chemotherapy arm. Hazard ratio was 0.64 with a significant p-value. And this is a forest plot looking at the subgroups that benefited, and you can see most of the subgroups are in favor of erdafitinib versus chemotherapy. There was also an improvement in progression-free survival of erdafitinib over chemotherapy. Median PFS was 5.6 months with erdafitinib versus 2.7 months with chemotherapy, with a statistically significant hazard ratio. In terms of overall response rates with erdafitinib was 45% versus only 11% in the chemotherapy arm. So the safety profile, for those of you who have used erdafitinib is a drug that has some very peculiar toxicities such as hyperphosphatemia, diarrhea, stomatitis, onycholysis, even ophthalmic changes. So what was seen in this study was not different from what we already know about the drug. Yeah, so the conclusion of this study, so patients with FGFR alterations who have had immune checkpoint inhibitors, erdafitinib is a better choice, which improves overall survival compared to run-of-the-mill chemotherapy. Whether in patients who have not seen immune checkpoint inhibitor, whether erdafitinib will be better than pembrolizumab, we don't know that. That arm of that study has yet to be read out. We await the results from that study. And so now with the multiple treatment options available in the second line setting, whether it is antibody drug conjugates, whether it is targeted therapy or chemotherapy, how do we sequence the treatment for our patients? So we know based on the Trophy 01 cohort, patients had progressed on platinum and immune checkpoint inhibitor, and there were about 18% of patients who had received prior enfortumab vedotin, and for patients who had received enfortumab vedotin, they found that response rates was in the range of about 20 to 30%. So far, we do not have any data of patients who have had sacituzumab and then followed by enfortumab vedotin. So essentially, if your patient has seen standard first-line therapy with chemotherapy together with avelumab maintenance, second-line treatment, it should ideally be enfortumab vedotin if patients have access. Thereafter, depending on whether they have FGFR alterations, then you can decide whether you want to move on to a next antibody drug conjugate or chemotherapy. So what do we see the landscape for urothelial cancer to be? If you just look at this, about 7 years ago, urothelial cancer was really very boring, not much happening. But this is the EV103 study. Essentially, the combination of enfortumab vedotin plus pembrolizumab is being investigated in the first-line cisplatin ineligible patients, and we have some preliminary results that shows a very impressive response rate of 73%. And you can look at the graphs here. There were about 15% of patients had a complete response as well. So These are very promising results, and we are looking at more first-line combination trials. So there's a EV plus pembrolizumab trial ongoing, as well as another antibody drug conjugate, disitamab vedotin, together with toripalimab, which is an anti-PD-1 antibody. So we await this data, we await the results from this frontline combination trials, and really, what do we see the future of advanced urothelial cancer looking like? So in patients who had no prior immune therapy, most likely in either 1 or 2 years, most likely EV plus pembrolizumab will likely be the first line treatment. And should they progress, platinum chemotherapy thereafter, either sacituzumab or erdafitinib. For patients who've either seen recent immune checkpoint inhibitors or for some reason cannot have immune therapy, then frontline treatment would either be platinum-based chemotherapy or EV alone, and then whatever they haven't had in the subsequent lines. For patients who are not eligible for EV, for frontline EV, then standard would be platinum chemotherapy plus avelumab, and then next line, depending on what they have not seen and whether they have FGFR alteration. This is likely to be the future for advanced urothelial cancers. So I would like to conclude by saying platinum-based chemotherapy followed by avelumab maintenance is the standard of care for frontline management of advanced urothelial cancer. As of now, immune therapy in the second-line setting is too late for most patients. First-line immune therapy does not get control of disease in enough patients. Chemo IO combinations have been disappointing in the upfront setting, and basically antibody drug conjugates are going to change the landscape of advanced urothelial cancer. So basically this is if you have a patient at this point of time with urothelial cancer, essentially first thing to do is assess platinum eligibility. Which are you going to give? Cisplatin, carboplatin? Really don't be too fussed about it. Ensure that they get platinum doublet if that is possible, and thereafter go on to avelumab maintenance, and hopefully your patients have a long duration of response. If they progress, then second line options are probably antibody drug conjugate, and at some point you want to do FGFR testing for these patients as well to see whether they will be eligible for FGFR inhibitors. So that's all I have, and thank you very much for your attention, and I'll be happy to take any questions that you have.
Okay, thank you for that. Excellent. Well, there's a really nice summary of the current landscape for advanced urothelial carcinoma, and I'm sure everyone has taken a lot away from it. We have a few questions that have come up in the Q&A, so if anybody has any further questions, do pop them in the Q&A for Dr. Tanuja. So maybe we can go for the first question, and we have that on the slide now. So on behalf of Dr. Adila from UMMC, can we use avelumab for a patient who is re-challenged with platinum-based chemotherapy? Good question. I guess for this question, we don't know whether this patient has had immunotherapy before.
So I'm assuming this, I'm assuming, Dr. Adila, may correct me if I'm wrong, patient must have had platinum-based chemotherapy, had some response, and then you went for a watch and wait approach, and disease probably came back, and now you have re-challenged with platinum-based chemotherapy, and now you're wondering whether you can use avelumab. Technically, based on the indication, this is not how the drug has been used. But have I used it like that before? Yes, I have. This obviously not on the label, but I think if your patient has responded to the platinum re-challenge, I would go on to give them avelumab maintenance, because truly that would probably be the best chance for them to get long-term maintainer, to have long-term disease control.
Thanks. Yeah, I would probably agree that we've seen sort of similar patients at our institute as well. Maybe they didn't have access to immunotherapy after their initial platinum, subsequently relapsed, and guess, although as you say, outside of the label, but if they're able to access it, it sort of makes sense that they may gain some benefit from that maintenance. I wonder, one sort of interesting question that sometimes comes up, if a patient is on, say, avelumab maintenance, and then they have a progression of their disease, and they have a very good response to platinum therapy again, would you ever consider putting back the IO? Or are you happy that this patient is now resistant to IO and you would watch and wait?
Generally, if I got your question correctly, Robert, so basically patient has progressed on avelumab and whether I would re-challenge with another immune checkpoint inhibitor like pembrolizumab. Is that the question?
So if you were to if they were to progress on avelumab and then be re-challenged with platinum and have a very good response to that re-challenge, even to sort of CR, would you ever consider putting them back on some sort of maintenance therapy? Or
no, I probably, if they have usually in most cases, if they were to progress on avelumab, generally in this I generally don't go back to re-challenge with platinum-based chemotherapy, because now we do have options. In the past, generally when we didn't have good options, but now we do have antibody drug conjugates. Generally, I haven't done that, but if patients had progressed on avelumab, generally, I think if you progress on avelumab, chances of you to get response again, probably very unlikely.
Yeah. Okay, so I hope, Dr. Adili, we've answered your question. If we haven't fully answered it, you can just type another question and let us know. Second question. So, hi, Dr. Tanuja. How often do you see a CR post-chemotherapy? And do you recommend avelumab maintenance for your patient? And how would that discussion go when the patient would like watch and wait? And if the patient were to do watch and wait, what is offered when the patient progresses? So I guess some of the things that were covered in your talk there, but how would you sort of summarize that?
Yeah, I think this is a great question. And this is something that I initially, when I started patients on treatment, it's something I grapple with a lot as well. So thanks for asking this question. So, okay, with chemotherapy alone, especially with cisplatin, if you use a cisplatin doublet, generally we say CR rates can be anything between 10 to 20% of patients with just chemotherapy alone. But if you looked at, if you remember my slide from earlier, there are patients in this avelumab maintenance trial, patients with CR were recruited to this trial as well. Unfortunately, what I have found for my patients who had chemotherapy, who have achieved a CR with chemotherapy alone, this CR tends not to be durable. The patients seem to have a relapse. So I generally would put patients on avelumab maintenance. And for these patients, if they continue to have CR, at the 2-year mark, sometimes I discuss with them whether we want to get off therapy, because I mean, if you've been having CR for 2 years on avelumab maintenance, I think it's not unfair to discuss whether we could stop treatment. And most of the time, patients want to be off treatment as well, because I mean, avelumab maintenance is once every 2 weeks. So that's generally what I do. But to answer your questions, for my patients who achieve CR, yes, I do speak to them about avelumab maintenance. And in terms of the watch and wait approach, I don't do it at all anymore, because I think there is very good data to show that I feel that that's the only way your patients can get good durable response, is to get those patients who have responded onto an immune checkpoint inhibitor. Great. I hope that answered your question.
Yeah, I think that's a very comprehensive answer. And I think the stopping at 2 years is something that, and I was going to ask that at some point, but I think that's something that a lot of people may have a discussion at least and consider doing. I suppose if for whatever reason there wasn't avelumab maintenance available and the patient were to go on to a watch and wait sort of pathway and then progress, then it would be sort of the standard second line options that you've discussed and gone through, whether that be immunotherapy or otherwise, depending on access. So we have a few more questions. So what would be the subsequent treatment offered to platinum ineligible patient who has progressed on immunotherapy? So that is quite a limited perhaps pool of options, but what would your thoughts be?
Yeah, so I think, I mean, previously, if you're telling me, I mean, different people say platinum ineligible. They use this platinum ineligible criteria is something that I really don't, I really favor. So I always look at it, are you chemotherapy ineligible? Because if you're chemotherapy, there are very few patients who cannot receive carboplatin and yet receive some other form of chemotherapy, at least in my experience. So I assume your patient is, if you're talking about a patient who is chemotherapy ineligible, then your treatment options are really quite limited. But if patient is still chemotherapy eligible, then you've got your antibody drug conjugates available. You may want to go and test for FGFR alterations and see whether that would be something that they can potentially get on FGFR inhibitors, or even down the line single agent chemotherapy like taxanes, vinflunin. These are some things that we have used before. Response rates are not that great, but it buys the patient some time.
Yeah, I think exactly right. I think this definition of platinum ineligibility is a bit of a nebulous.
Yeah, I still can't wrap my head around it, truly, but
and as always, it's a question of why are they ineligible? Is it going to be the renal function? Is it their performance status? In which case, as you say, supportive care may be an option, or all of the other options that you have mentioned for those that are otherwise fit for some sort of treatment. Next question is, Dr. Tanuja, how is your adverse event management experience with Pembro and enfortumab vedotin?
Okay, so that's again a great question. So I have used this Pembro plus EV combination as part of trial setting. I have realized that quite a lot of patients required dose reduction. It's a bit difficult to do the EV dose of 1.25 mg per kg. A lot of patients needed to drop to 1 mg per kg. I have seen patients. I have seen a patient with Steven Johnson's reaction as well. That was really scary, but the trial, because I've used it as part of trial, it's they are very fixed. There are very fixed protocols on how you manage these toxicities. But if I were to use it out of a clinical trial protocol, let's say if I want to offer Pembro plus EV in my cisplatin ineligible patients upfront, I would probably decrease the dose of EV to 1 mg per kg as a start and see how patients respond. And because it's day 1, day 8, day 15, I know a lot of us will probably see them 4 weeks later after the first cycle. I've realized that is something that you cannot do for patients who just started on EV. You need to watch them very closely. So I will see, after starting this combination, I would see them within the next week and see how they are tolerating treatment, especially the skin toxicities.
Yeah, I think there was a few discussions at ASCO this year in some of the symposiums regarding ADC AE management, and I think the skin toxicity for EV is one of the major issues that we all have to sort of be very vigilant about. And then I don't know how your patients have fared, but sort of the limited experience, again, sort of within clinical trials that we've had here, we find that peripheral neuropathy is quite a real toxicity that our patients get as they sort of get a cumulative dose of EV. And in one case, we did have to sort of discontinue therapy for a non-resolving peripheral neuropathy. Is that something that you've seen a lot?
I haven't seen a lot of peripheral neuropathy, but I also realized that if you dose reduce to 1 mg per kg, you don't see so much of that. But that's probably not on the drug indication, but this is something that I sort of have done based on my experience. Yeah. Okay,
let's move on to the next question. We still have a little bit of more time before we go to the case discussions. So the next question was regarding definition of stable disease post-chemotherapy and the duration of time that you would wait before initiating avelumab.
Yes, so again, great question. Generally, as long as there is no progression of the disease, I would put them on avelumab maintenance, and I don't wait. So after they have finished their either the 4th or 6th cycle of chemotherapy, usually they will get a scan, and that is usually about 3 weeks to a month later from the last cycle of chemotherapy. If that scan shows that they are responding or stable disease, I start them on avelumab maintenance immediately. I don't wait. That there's no waiting period that I use, and patients essentially don't have an issue tolerating getting started on the avelumab. Is that the same with you, Robert, or do you do something else?
Hoping to go into maintenance.
Sorry,
Oh, so the sixth question is, how would you decide on 4 versus 6 cycles of platinum chemotherapy?
So how I do this is after the 4th cycle, so I generally do a scan after every 2 cycles. So after the 4th cycle, if let's say if compared from the 2nd cycle to the 4th cycle, is if there is continued response and the patients are continuing to respond, I will continue to 6 cycles. If it's stable disease, there's no difference in the scan after the 4th cycle and the 2nd cycle, then I stop at 4 cycles and I go on to avelumab maintenance. I also look at the patient and how they are tolerating the chemotherapy. If obviously they have seemed to have achieved their maximal response and they're very fatigued, then I would probably stop at 4 cycles. As you can see from the trial data, really not much difference whether you do 4 cycles or 6 cycles.
Sure. Fantastic. Okay, we have one last question in the Q&A chat. Asking whether you do upfront PDL testing before initiating avelumab.
No, I don't. From the institution I came from and where I am now, we don't do PDL1 testing. Basically, role of PDL1 testing in urothelial cancer. I mean, there's a lot. If you look at all the different trials, they've used different tests, and essentially PDL1 as a biomarker in immune checkpoint inhibitor is not. It's not a great marker. It's not useful. It doesn't tell us how to choose our treatment. And if you look at the avelumab study, patients benefited regardless of whether they were PDL1 positive or whether they were PDL1 negative. So at this point of time, I don't do PDL1 testing for my urothelial patients.
Yeah, would be similar, from our institution as well. Okay, so that's the questions in the Q&A chat. We also had a question from one of our panelists that I think perhaps we can touch upon that when we have our panelist discussion, after discussion of their cases. That's from Dr. Gerardo Cornelio regarding local treatment after induction chemotherapy and CR. So we can perhaps bring that question in at a later point. So I'd now like to invite our panelists to the fore. So we're lucky to have with us 3 panelists. So we have Dr. Daniel Wong, senior consultant from the Pantai Hospital in Ayakero in Malaysia. We have Dr. Wulio Rajepto, consultant medical oncologist from Dr. Cipto Mangunkusumo Hospital in Jakarta, Indonesia. And we have Dr. Gerardo Cornelio, director of the Cancer Institute at St. Luke's Medical Center, Global City, Philippines. So welcome, and thank you for joining the panel. I think we will move on to the first case discussion, and then we're going to have some time for what should hopefully be quite a fruitful further discussion. Okay, so I'll hand over to Dr. Wulio.
Okay, thank you, Dr. Robert. I will present a short management of bladder cancer at our center, Dr. Cipto Mangunkusumo, General Hospital, Jakarta, Indonesia. Slide. Oh, I will share my screen.
Yeah, I think you can share your screen if you have your slides there.
At my center, first-line cisplatin eligible, we will administer cisplatin and gemcitabine. But if cisplatin ineligible, we will administer carboplatin and gemcitabine. First-line immunotherapy, pembrolizumab or atezolizumab, has not covered by our national health insurance, even though the drug is available in Jakarta. And if there is no progression, we will observe because avelumab is not yet available in our center, maybe next year. So if the disease is progressed, we will change into other chemotherapy, for example, paclitaxel or docetaxel. And later line treatment, just like enfortumab vedotin or endafitinib, not yet available in our center. Maybe this is the characteristic of our patient, bladder cancer, P52N0, post-radical cystectomy, orthotopic neobladder in 2021. No adjuvant chemotherapy then because only pathologic T2. However, metastatic lung disease into 2023, and we plan to administer cisplatin gemcitabine every 6 weeks for 4 until 4 cycles, and the patient is fit for cisplatin. And if there will be no progressive disease, we will only observe, and if in the observation period there is progressive disease, we will change into second-line chemotherapy, paclitaxel or docetaxel monotherapy. I think that's my case. This is for muscle invasive disease. I think we do not discuss the muscle invasive bladder cancer in this opportunity. Thank you very much.
Okay, thank you, Dr. Julio, for that short case. We don't have any additional questions at this point, so perhaps what we can do is pass over to Dr. Gerardo Cornelio, and then we can discuss based on these two sort of cases or reviews and any Q&As that come in. So, Dr. Gerardo, I'll hand over to you.
Okay. Can you see my slides?
Yes, we can. Yeah.
Okay. Good evening, everyone. I would like to present our case. First of all, I would like to thank Merck for having me here to be with this distinguished panel. Now, these are the disclaimers and my disclosures. So I'll be presenting a case of RN, a 54 lady, Filipino with known history of hypertension, controlled with medications, smoker for 30 years, about 10 sticks per day, non-alcoholic beverage drinker with a family history of colon cancer. History of present illness, about 7 months ago in December, patient experienced on and off hematuria. He consulted in January 2023 with a urologist and given antibiotics and worked up showing a bladder mass on CT scan. This was a 2 intravesical masses contiguous with each other in the lateral walls of the urinary bladder. She underwent TURBT with biopsy showing invasive high-grade carcinoma with glandular differentiation, and tumor invaded the muscularis propria up to the detrusor muscle. There was no definite lymphovascular invasion, and immunohistochemical workups showed a primary urothelial malignancy. They did a PD-L1 testing, CPS score of 70 to 80%, MSS. February 2023, hypermetabolic disease in the urinary bladder wall correlates with a residual tumor and showing metastatic nodes evident along the left side of the pelvic cavity, showing a T4 disease. Patient underwent MDT and thorough discussion with urology and radiation oncology services. And we started this patient on induction platinum-based chemotherapy. So you can see here in the PET scan showing the activity in the bladder, in the pelvic sidewalls, aside from the bladder mass. So if you look at the NCCN guidelines, here you can see that for this T4B disease, you can start off with either systemic therapy or concurrent chemoradiation therapy. So we started off with systemic therapy first, and then we moved on to evaluate this patient afterwards. So this was discussed by Dr. Tanuja. Patients will need to be evaluated whether these patients are platinum eligible or ineligible, and you have those the different regimens, the dose-dense MVAC or gemcitabine cisplatin. So we started this patient on gemcitabine cisplatin, and after 2 cycles, there was near complete response with complete metabolic regression on PET scan. She completed 4 cycles of gem-cis, and MRI showed complete response. And then we discussed this again, and she went on to undergo concurrent chemo-RT as decided by the patient, since she refused any surgical intervention. So you can see here the 2 masses in the pelvic wall gone after at least 2 cycles of therapy. So again, this was discussed. So we started this patient on gemcitabine and cisplatin. So the discussion points that we have here in patients who underwent complete response after induction chemotherapy in this disease, is there a role for maintenance immunotherapy after concurrent chemo-RT? We know that in the Javelin 100 study, we know that these patients had residual disease or stable disease after completion of induction therapy, and they were put on maintenance avelumab. And should we just do maintenance avelumab after the induction therapy, as shown in the Javelin 100 instead of chemo-RT, and other treatment recommendations. So with that, thank you very much for your attention.
Okay, thank you ever so much, Dr. Gerardo. So I'd like to just encourage any of the attendees, if they do have questions for any of our panelists, please do drop them in the Q&A chat. And otherwise, I'd like to sort of open the floor to the other panel members. So Dr. Wulio, Dr. Daniel, Dr. Tanuja. I guess sort of we can discuss Dr. Gerardo's case. You had a few sort of points of discussion that we just heard. First off, regarding the role of consolidation therapy after induction chemotherapy. And obviously your patient, Dr. Gerardo, had a great response to chemotherapy and went through the chemo-RT well. Maybe I can open to Dr. Daniel Wong. What are your thoughts regarding that, and sort of how do you practice in such cases?
Yeah, I completely agree with what Tanuja mentioned earlier. I think in my personal experience, the duration of response, even if there is complete response, is not very long. And I think if we have an option for maintenance and it's been shown to improve overall survival, I think that should be done even if there's complete response. So definitely I'll go for that. Having said that, though, in the recent past, I've not had a patient with complete response. All of them have been very good partial response. But yeah, my first thought would be to continue with avelumab if there's no other contraindications to IO.
Thanks. And Dr. Tanuja, would you like to sort of add to that?
Maybe can I just check with Gerardo? Maybe I missed out something. So your patient essentially had muscle invasive bladder cancer had
Right.
induction chemotherapy, responded very well, had concurrent chemo radiotherapy, correct?
After the chemotherapy. Yeah.
And this was in the curative setting, right? Correct. It was not that
Yeah.
he didn't have any metastatic disease.
No, the pelvic sidewall that did light up on the PET scan initially disappeared. So the question is now, in that setting wherein you do have a complete response both on MRI and PET scan, would you go for just maintenance of avelumab or would you go for local therapy?
And this pelvic side wall lesion was covered in the chemo RT field.
Yes. Yes.
Okay, so essentially we've treated him as if this is curative, right? Like a muscle
right.
invasive disease. In this case, I think it's a little bit, it's not your typical it's not your typical Javelin bladder 100
Yeah,
patient, right?
exactly.
Yeah, so I mean, I think if the patient has had complete response and you're treating this really as a muscle invasive disease, I think giving him maybe just giving him a watch and wait approach may not be wrong here, because this is not your typical patient. But just having, I'm sure it's the same with you, with the urothelial cancer patients, you essentially, we are just buying time for them, right? Even though they have done very well after chemo RT, they will usually relapse at some point of time. And depending on when he relapses, maybe let's say 6 months down the road, 1 year down the road, I will probably re-challenge with do the gemcitabine, platinum, and then avelumab maintenance there. That will probably be what I do. I'm not sure what the other panelists feel.
Would you not consider looking at NGS after, if this patient recurs, for example, looking at FGFR or trying out enfortumab vedotin plus pembro on recurrence rather than re-challenging with platinum-based
Right,
chemotherapy?
because yes, that is fair enough, but your patient has done really well with gemcitabine platinum and has received and has achieved complete response. So and the thing is, depends on the duration from when you stop treatment to the relapse. If this is anything more than 6 months, I think really it will be fair enough to do a re-challenge. But of course, if you want to do the EV plus pembrolizumab, and if the excess is not an issue, then why not? But and as well, why not do this if usually in our setting as well, excess is an issue with doing NGS testing and things like that. So but if cost is not an issue, yes, definitely do FGFR testing upfront.
Thank you.
Yeah, I think that, I mean, it sounds quite reasonable if, as you're saying, Dr. Tanuja, if the patient's had such a good response to platinum therapy and we've almost treated him for cure, we've treated him like a local disease, then it's quite reasonable to consider watch and wait, I would think. And I mean, I just wonder also, while we're on the topic of, well, around the topic of earlier stage disease, muscle invasive bladder cancer, obviously we now have the FDA approval for adjuvant nivolumab for those patients that have undergone neoadjuvant chemotherapy or not, or declined with high risk invasive urothelial carcinoma. Whether that's going to cloud our sort of advanced space subsequently if they relapse. And I just wonder if anyone has any thoughts on treating patients who have had adjuvant nivolumab who then relapse subsequently.
I think, Robert, that's a great question. I think this is something that we've all been talking about. So because adjuvant nivolumab is 1 year, right? So you do adjuvant nivolumab for 1 year. I think whether you give the patient immune checkpoint inhibitors again, whether you do the EV plus pembro upfront, or whether you do the cisplatin followed by avelumab, will really depend on the time, the duration from when you stop immunotherapy to when the relapse happened. I think if the relapse is more than 1 year, I think it is not unfair to go down the immunotherapy route. But if it's a very early relapse from the adjuvant nivolumab, then probably either one of your antibody drug conjugates, probably. That's my feel. Maybe you can ask the other panelists.
Yeah. Dr. Daniel, Dr. Julio, or would you want to comment on that?
I haven't used nivolumab in the adjuvant setting as yet, but yeah, I think there's not a lot of data about having further challenge with immunotherapy in probably many other sites. But I'll be tempted to, yeah, if the duration, if the treatment-free interval, a disease-free interval is quite long, or progression-free interval is quite long, then maybe more than a year. Yeah, I think it's fair enough. Why not re-challenge?
Yeah, like you say, I think it's a data-free space that a lot of sort of tumor groups are trying to tackle now that immunotherapy is coming earlier into the either neoadjuvant or adjuvant setting. We have a question from the attendees, from one of the attendees. So some patients refuse chemotherapy, and can avelumab be given without prior chemotherapy? And this is from Dr. Clarence Liu, urologist from Kuching.
I think great question. I wouldn't do that because you are not going to get the kind of response that you're going to get with chemotherapy. So essentially how I look at it is basically the chemotherapy does the majority of work in decreasing, decreasing your tumor burden, and avelumab is there for is more there for maintenance. As you can see, the response rates are about 10% or so. So and based on our data that we have had with using pembrolizumab and atezolizumab in the frontline setting, you don't get the kind of responses that you get with chemotherapy, and thus the FDA withdrawal of immune checkpoint inhibitors label in the frontline setting. So I won't do that. I would highly encourage the patient to consider chemotherapy. I mean to consider chemotherapy, and if in the event the patient is cisplatin ineligible, then maybe if they have access, then EV plus pembrolizumab.
Thank you. Thanks for that answer. Dr. Gerardo, did you want to comment on that as well?
I just have a question with Dr. Tanuja. You said you don't consider testing for PD-L1. I know it's not really part of the clinical trials, but if you look at the data, the dose that had higher PD-L1 did better than those with negative PD-L1. Do you agree? So do you think in that setting, would you think that you might probably see more responses? I know it's not going to change your treatment, but yeah, probably.
You're saying in the Javelin, you're talking about the Javelin study, the patients who had PD-L1 positive.
Right.
Yeah, but having said that, even the patients who don't have PD-L1 positive have responded. I get where you're coming from, but I think in terms of it's not something that's done as reflex testing, and at this point of time, it doesn't really affect our management, because whether you're PD-L1 low, whether you're PD-L1 high, it doesn't change your management, right? So even if the patient is PD-L1 low, and if he has responded to first-line chemotherapy, you would still go on to avelumab maintenance. And just based on clinical practice, I've seen patients even for some reason, those who have had PD-L1 and those who have done the NGS testing, even those with PD-L1 score of 0% have responded, have long-term response to avelumab. So at this point of time, I wouldn't do it as routine.
Dr. Gerardo, is that something that you're sort of usually doing in your practice in terms of PD-L1 testing?
Yeah, but if you look at the initial studies using pembrolizumab before, I think the data did show some benefit with those with higher PD-L1 scores. Am I correct?
Yeah. I mean, I think we saw with the initial pembrolizumab, even the initial approvals looking at PD-L1 positive patients. And if you go back to, as we mentioned earlier, the CheckMate study in the adjuvant setting, CheckMate 274 adjuvant nivolumab, I think there was a greater degree of benefit in the PD-L1 patients, and that was reflected not in the FDA but in the EMA approval. So I think there's been mixed signals from the PD-L1 biomarker, and I guess it's unfortunate we don't have a better biomarker or more reliable biomarker perhaps in urothelial carcinoma, and hopefully that's something that will sort of be updated in the future. We hope, as they do translational studies from a lot of the trials that have been ongoing. Dr. Wulio, I was just sort of regarding this question, do you see a lot of patients who refuse chemotherapy when they come to you? Or?
Yeah, in our center, the main treatment is chemotherapy. So we will approach to the patient to administer chemotherapy. But if the patient do not want, we will offer pembrolizumab, not avelumab, to the patient if the patient can afford the treatment of pembrolizumab.
Sure. Yeah, almost making themselves platinum ineligible, I guess, in their decision. So hence going down that route. Okay, we don't have any other questions in the Q&A chat at the moment. I just wanted to touch upon, I didn't bring it up earlier, regarding avelumab use and some of the adverse events with avelumab that perhaps we don't see with other immunotherapies. Something that we've experienced at our center is the infusion related reactions. Perhaps I could ask Dr. Daniel, is sort of with your use of avelumab, have you seen that as an issue in any of your patients?
No, I've just had 2 patients who went through the NAME patient, the early access program, and both of them were fine. Yeah, I was just about to follow up to say that no issue with the infusional reaction. In fact, there was hardly any immune-related reaction. The main issue was for both of them. They within about 8 weeks or so, clearly when they were progressing, and it was confirmed radiologically as well. So again, I'm just following up your point, Robert, saying that it'd be good if we had a more robust biomarker for the future. Yeah, but no major issues with toxicity for the 2 patients on avelumab.
Okay. Yeah, we actually had a couple of patients at our center who had quite a abrupt and significant infusion-related reaction, ended up in our ICU. And there is that FDA label, and in the study was recommended regarding antihistamine use and paracetamol for the few initial cycles. I don't know if there's anything sort of similar to any of the other panelists have experienced.
I haven't so far. My experience with avelumab infusions, I mean, has nothing been out of the ordinary. So what happened to your patient that had the reaction? Yeah,
so as in we've had quite a few patients without any problem. One or two patients with sort of mild grade 2. It almost presents like a hypersensitivity reaction. But then we had 2 patients that were more severe, going towards anaphylactic with desaturation. So we treated them just similar to an anaphylactic reaction, you know. So IM adrenaline, IV steroids, IV Benadryl. Both of them responded to treatment. They turned around and they were able to sort of get out of the ICU, and there wasn't much in the way of residual morbidity from that. But obviously, with such a severe reaction, we weren't able to think about rechallenging. The grade 2 HSR, the grade 2 HSRs that we've seen, we have been able to rechallenge with a higher dose of antihistamine, and they seem to be tolerating it okay. Yeah.
Does avelumab also has side effect, immune reaction adverse event, for example, hyper or hypothyroid, colitis, diarrhea, hepatitis or nephritis, Dr. Tanuja?
Yes, they do. So your avelumab has any of those, any itis essentially can happen with avelumab, just like your other PD-1 or PD-L1 inhibitors. So the same things like, you know, doing a baseline thyroid function test and educating the patients of immune-related reactions needs to be done. Yeah. But unlike Robert, I have not seen a severe reaction that required severe reaction that required me to stop the drug. So I'm quite thankful for that, I guess.
Yeah, I think the rates are low. I think we were just unfortunate. Yeah. I think the reported rates in the study for grade 3 reactions such as that are even less than 1%. So it's quite low. Yeah.
That's why I tell my patients, if you give enough, sooner or later, it's going to happen. So you just have to warn them. You just have to warn them in the consent.
Yeah, absolutely. Yes. Okay, no further questions have popped up in the Q&A. Any other points that any of the panelists wanted to bring up at the moment?
I learned something useful from Tanuja today. Thank you very much. I'm not going to stress out about carbo versus cisplatin. I grew up, I was trained in Birmingham where they did a lot of the cisplatin trials, and that was it was 2002 or something like that. They were talking about the split dose cisplatin. So that was where I learned. So I do a lot of split dose, but from today onwards, there's going to be more carboplatin on my side once the EGFR drops a bit lower. Yeah.
Yeah, no, you're absolutely right. So initially I was doing that as well, but as I did more reading and, when I attended all these conferences and we spoke to experts like Tom Powells and all that when he came over, I mean, they said, really don't fuss about it, right? And it's so much easier to just give the carboplatin, right? So why not? So I've decided to save myself all the stress. And maybe another thing to bring up, I think there's this also, so the avelumab dose is 10 mg per kg every 2 weeks, right? That's the weight-based dosing. There's also a flat dosing of 800 mg every 2 weeks that has been FDA approved. So I mean, if you don't want to calculate the weight, you can do the flat dosing. And so I think some people always ask, which do you use, the 10 mg per kg or the flat dosing? Essentially, my answer is always I go for the one that is cheaper. So if you have a smaller patient, then I will probably do the weight-based dosing because then the cost is just less for the patient. If you have a bigger patient, then I just do the 800 mg. But essentially, both these doses are found to be just as efficacious.
Yeah, I think that would be something similar. Yeah, go for the lowest cost for the patient from me as well. Yeah, I would echo Dr. Daniel about the cisplatin and the carboplatin. I think it's something that we've always, or with a lot of our patients, we sort of do a 24-hour collection, and then even, some patients have had sort of nuclear medicine scans. There's been a lot of discussion on it, but ultimately, like you say, it's probably easier and doesn't make a difference in terms of outcomes, as we see from the results that you showed. For those patients with borderline creatinine clearance, carboplatin is a great option, adequate option for them. Dr. Woolio, Dr. Jurado, what are your thoughts in terms of, this cisplatin ineligibility and using carboplatin?
Yes.
Yeah, go ahead. Sorry.
Yes, I will use carboplatin if the patient is ineligible. I do not use split dose of cisplatin.
Yeah, the same thing. I think carboplatin is a good alternative, as was discussed. Yeah.
And would most people use a cutoff of 60 per the sort of the classical Galsky, or I know with the POUT trial, sort of people became a little bit more comfortable going to 50 mils per minute as a creatinine clearance cutoff. I'm not sure how most of us generally practice. Sort of here for myself, if it's between 50 and 60, if I'm thinking of cisplatin, I might do a second, maybe a 24-hour collection just to be sure that I'm not getting that level wrong. What would other people think? Dr. Jurado?
Well, I always work with a nephrologist with me because eventually, as you go on, I think your creatinine levels are going to creep up. So better be prepared so that I can finish the cycles.
Yeah. Yeah, I think it's great if you have a good relationship with your nephrologist when you're dealing with platinums. Dr. Woolio, you sort of stick quite strictly to the Galsky, or?
Yeah, I use 60, 50 and 60, I think.
Okay. Okay. Just have a quick check for further questions. I don't think we have any. Any other questions from the panel members to anybody? Before we think about.
I just have a question for Dr. Tanuja and Dr. Robert. If you had this patient, would you start this patient on, let's say, the chemotherapy platinum containing? Would you go ahead and straight maintain this patient on avelumab, for example, or do a local therapy as well?
Sorry, for which patient you're
The patient I presented, you know, you have two lesions in the pelvic wall. So you start this patient with chemotherapy, platinum based, because they are platinum eligible. But would you, when you get into a very good response, would you rather put them on avelumab instead, or still go for local therapy?
I think that's a great question, but
I think you have it.
seeing that you have such a good response, and I think you're trying to go for curative setting. I think going for the concurrent chemo RT is not wrong, but I would explain to the patient that this is not standard of care, but we are trying to give you the best opportunity of cure, and just go in with eyes wide open and see how things turn out. But I would definitely agree with your management.
Yeah, sorry, my internet connection just was a bit broken up just now. Yeah, I think I would echo what Dr. Tanuja said. I think this is these are often complex cases and require quite a bit of discussion in the multidisciplinary tumor board, you know, whether can we even think about radical surgery, as I think was discussed in your case, but the patient declined, whether the RT field can cover the regions that we're thinking of, and really what was the extent of the pre-treatment lymph node disease or pelvic wall disease, sort of in terms of the chances of really giving this patient a durable response. Dr. Daniel, would you have any sort of comment on that or want to add?
No, I completely agree. I think these are the challenges when there is a complete response. It reminds me of what we do when you have metastatic renal cell carcinoma and you have complete response. You know, what do you do with the kidney, which was super big before? You know, there's not a lot of evidence that certainly that will, but it might have caused the patients a lot of symptoms before. So whether it is good when it's really small or shrink completely, whether we should go for cytoreductive surgery or not, I think that's there's going to be a discussion between ourselves and the patients, particularly if they had lots of symptoms in the past.
Yeah. Dr. Woolio, is this something that you would think about in your practice?
Yeah. The case is muscle invasive bladder cancer. The response is very good, yeah, Dr. Gerardo. I think I will only observe the patient until the patient is a progressive disease.
Sure. Yeah, I think in this case, no right or wrong, it says the complex case. But great to hear everyone's thoughts on that. I think we've come to about 7:30 or just over. So if there are no further questions, I'd like to thank all of our speakers again and our panelists, Dr. Tanuja, Dr. Daniel, Dr. Woolio, and Dr. Gerardo. And obviously thanks to Merck for putting this talk together. I've definitely taken something from it, and I hope all of the attendees have as well. I think there's some feedback, I think that may go out to the attendees. So please do respond to the poll that should be popping up on your screens now. And that would be very helpful, I think, for the organizers for future events. Okay, so if there's nothing else that anyone would like to add, probably bring it to a close tonight, and everyone can go and enjoy the rest of their evening.
Thanks, Robert.
Thank you.
Thank you, Robert. Thank you,
you.
Tanuja. Thank you. Cheers.
Thank you.
Thanks, everyone.
Good night.
Good night.
As we strive to continuously improve and bring you the best webcast experience, we value your opinions highly. Here are some event poll questions which will take you less than a minute. We appreciate your participation. Please make your selection now that the poll is open. We've come to an end of the webcast, and once again, our heartfelt thanks to our esteemed and distinguished panelists for the interesting and informative presentation and case discussions, as well as to our attendees online for making time and joining us throughout this insightful webinar, brought to you by Merck. Stay safe, take care, and have a wonderful evening.